This presentation is about the alterations in hematological function. We're moving on to the next section and we're going to talk about the different types of leukemias. And leukemias are a clonal malignant disorder of the bone marrow, and it's usually of the blood, but not always. The common pathologic feature of all types of leukemia is that there is an uncontrolled proliferation of malignant leukocytes. And this is going to cause an overcrowding of these leukocytes in your bone marrow. And if there's an overcrowding in the bone marrow, it's going to decrease the production and the overall function of normal hematopoietic cells. You're also going to see chromosomal abnormalities and translocations. These are common in the majority of the leukemias, but not all. When these genes are mutated, they can create genomic aberrations that block cell maturation, and then they activate this pro-growth signaling pathway that prevent apoptotic cell death. And in time, the overall classification of leukemia has been increasingly complex because there's been notable changes with new research. The changes create a blurring of lines in some of the ways that we were using to distinguish between the different categories. So there once were very discrete categories of lymphomas and leukemias, but some cancers are now known with lymphomas and leukemia presentations. And the evolution of leukemia isn't unusual during the progression and the progression of incurable types of lymphomas. You'll see them progress actually to leukemias. The World Health Organization actually has 5 broad categories. We have immature B cells, mature B cells, immature T cells, and the mature T cells and natural killer cells. The last one is the Reed-Sternberg cell variant types, which is a Hodgkin's lymphoma. When we talk about leukemias, we talk about acute and chronic. Acute means there's a presence of undifferentiated or immature cells. Usually they're the blast cells. And with chronic leukemia, we have predominant cells that are mature, but they don't function normally. All leukemias have certain pathophysiological features that are in common. Most of the lymphoid neoplasms are going to arise either from the B cell or the T cell differentiation pathways. The majority of lymphoid neoplasms are from the B cell origin, followed by T cell, and then rarely would it be the natural killer cell tumors. Abnormal immature WBCs, called leukemic blasts, will fill your bone marrow and spill into the blood. And when these leukemic blasts crowd out the bone marrow, it's going to cause cellular proliferation of the other cells to decrease and also to cease as well. It's just a crowding out, not enough room. Normal granulocytic, monocytic, lymphocytic, erythrocytic, and megakaryocytic progenitor cells will cease to function, leading to overall pancytopenia, remembering that this means a reduction in all the cellular components of your blood. While this is happening, genetic translocations can also be observed in the mitotic errors. The most common genetic abnormality is the reciprocal translocation between chromosomes 9 and 22, and we call this the Philadelphia chromosome. The Philadelphia chromosome was first observed in someone with chronic myeloid lymphoma, and then now we can actually see it present in 95% of all patients with CML. There are some individuals that have AML and ALL that also will present with Philadelphia chromosome, but not as common as chronic myeloid lymphoma. This translocation of the chromosome 9 and 22 results in a new fusion of the BCR1 gene region from chromosome 22 and the proto-oncogene of the ABL1 from chromosome 9. So it joins, resulting in the expression of this uniquely fused oncoprotein. This variant proves to be essential in the transformation into leukemic cells. In most leukemias and lymphomas, a single major genetic abnormality, such as the 9 and 22 translocation or the Philadelphia, doesn't lead to an aggressive malignancy. The initial event is usually followed by a series of secondary genetic changes, and then the original tumor becomes more unstable and more diverse. And in a majority of the cases, leukemic cells are then ejected into the blood, and then this is where they're going to accumulate. They may infiltrate and accumulate in the liver, the spleen, your lymph nodes, and the other organs throughout your body, causing some of the clinical manifestations that you see in the leukemia. The presentation of these large numbers of leukemic cells may be the most dramatic indicators of leukemia. However, it's still just a primary disruption of the overall bone marrow itself. The signs and symptoms of leukemia that you might see are fatigue. Think about leukemia causing extreme tiredness and weakness because of the disruption of normal blood cell production and function. You might also see bleeding because of the decreased number of platelets, and platelets are responsible for clotting. Petechiae, these are the purple and red spots that you see on the skin caused by below the surface bleeding, and this appears with those pinpoint-sized dots, or purpura, the larger patches. Ecchymosis or bruising can occur due to, again, bleeding beneath the skin, and you'll see discoloration. With leukemia, patients may present with recurrent or persistent fevers because of the overall symptoms of infection due to the underproduction of blood cells. You'll have unexplained weight loss because there's an increased metabolic demand due to cancer cells that is going to impact your appetite and also nutrient absorption. Your patients may undergo bone pain because especially in the long bones and the joints, because there's an abnormal accumulation or overcrowding of these cells in the bone marrow. Your uric acid may also be elevated because leukemic cells can break down very rapidly, and this leads to an increased level of uric acid in the body. This is what's causing the joint pain and also can cause kidney issues as well. You may see enlargements in the lymph node, the liver, the spleen, because of the abnormal amounts of leukemic cells, and it causes discomfort and swelling in these areas. Infection, because leukemia will weaken your immune system. It makes patients more susceptible to infection, and it results to frequent and more severe infections. We also might even see, in some cases, leukemia causing CNS type symptoms, headaches, seizures, confusion, and other neurological abnormalities as well. Now, it's important for us to note that these specific signs and symptoms can vary depending on the type of leukemia, the stage, the individual factors of the individual. ALL progresses from malignant transformations of B or C cell progenitor cells. These are stem cells. In most cases, patients diagnosed with acute lymphocytic leukemia are children. However, 20% of adults are diagnosed out of the total patient population with ALL. And in adult, the mortality rate is significantly higher. There is a significant difference too between the incidence of ALL in adults and in children, and this is because of the biology of the disease itself. When you have B cell ALL, this is mainly in children, and it's strongly associated with chromosomal aneuploidy of various types. However, with adult ALL, this is a mixture of cancers that have to do with precursor B and T cell origin. The identification of these mutations is ongoing and includes mutations that drive cell growth and mutations that also increase the tyrosine kinase activity. AML is the most common adult type of leukemia. Acute myelogenous leukemia is due to genetic alterations or alterations in genes that encode the transcription needed for normal myeloid differentiation. So therefore, that differentiation becomes halted or arrested. The mutations will then affect the epigenome, suggesting that epigenetic alterations are key in AML. And these mutations can lead to the proliferation of activating growth factors that signal a decrease in apoptosis. Then the bone marrow and peripheral blood are characterized by leukocytosis and a predominance of blast cells. With an increase in these immature blasts, they're going to displace all the normal myelocytic blood cells, the megakaryocytes and the erythrocytes that would have normally been there. And this displacement can lead to complications of bleeding, anemia, and even infection in your patient. There are hereditary conditions known to increase the risk of AML, like Down syndrome, Bloom syndrome, and Fanconi aplastic anemia. Most of the clinical manifestations are going to occur within days to a few weeks of the first symptoms, and usually it's an abrupt stormy onset, which is more prevalent in ALL. The clinical manifestations are going to be a variety of different type of symptoms, but they're generally pretty similar across both acute lymphocytic leukemia and acute myelogenous leukemia. The mechanisms that are associated with these manifestations can be looked at more closely in your textbook, but the signs and symptoms are really related to bone marrow depression. This is going to include fatigue caused by anemia. The bleeding is going to be resulting from thrombocytopenia and increased fever because of infection. Now, the bleeding can occur in many different areas: the skin, the gums, your mucous membranes, and even in your GI tract. You might even be able to see visible signs of petechiae, ecchymosis, discoloration of the skin. You might see bleeding of the gingiva or the gums, hematuria, so bleeding in the urine, and even mid-cycle or heavy menstrual bleeding. Sites of infection are commonly the mouth, the throat, the respiratory tract, your lower colon, urinary tract, and skin, usually by E. coli, Pseudomonas aeruginosa, and Klebsiella pneumoniae. Now, fevers are early sign, but you can also experience chills during these infections as well. Some patients may also have anorexia, which is accompanied by weight loss and a diminished sensitivity to sour and sweet tastes. Patients may have muscle wasting, difficulty swallowing, and even enlargement in the liver, the spleen, and the lymph nodes. But this is more commonly found in ALL. Liver and spleen enlargement can most commonly occur together, and those leukemia patients that experience abdominal pain and tenderness are not feeling uncommon symptoms. Joint pain and bone pain is a result from leukemia infiltration secondary to the stretching of the periosteum in the bone. There are also neurological manifestations like cerebral bleeding. Patients may complain of headache, vomiting, papilledema, you might see on exam, facial palsy, blurred vision, and even auditory disturbances. In some patients, meningeal irritation can also occur, And this is because the leukemic cells are infiltrating the cerebral or the spinal meninges. How we diagnose acute leukemia is through the examination of your blood cells and your bone marrow. For ALL, there is diagnostic confusion with AML and other types of leukemia. This is not very uncommon. So it's critical that we obtain an accurate diagnosis because there's a difference in the treatment and also the difference in the prognosis of ALL and AML. It's also important because bone marrow aspirates need to be done by an experienced oncologist, hematologist, or a hepatopathologist. This is so that they can interpret and stain the specimens specifically for a diagnostic reason. We typically will treat acute leukemias with chemotherapy in various combinations, and this is the treatment of choice. There's other types of treatments that also include radiation, chemo with stem cell transplant, and other drug therapy as well. Supportive measures will include transfusing blood because there will be anemia, antibiotics for infection, antifungals, and antivirals. It's also critical that stem cell transplants are done in the hospital with very experienced staff because the procedure is at high risk for infection, and also having experienced staff for the recovery phase as well. So many patients can actually attain complete remission, but you have to be very aggressive with the treatment overall. And the treatment is really divided into two phases: remission induction, which is we're trying to attain remission, and then the post-remission is the maintenance of remission. You will see myelosuppression in both the consequences of leukemia and the treatment for the disease itself. And so you do need hematological support with blood products and granulocyte colony stimulating factors, or granulocyte macrophage colony stimulating factors as well. And this is going to shorten the time of neutropenia and improve the survival rate and reduce the risk of infection. There are two main chronic leukemias as well. There's chronic myelogenous leukemia, CML, and there's chronic lymphocytic leukemia, which is also called CLL. Now, CML is called chronic granulocytic leukemia and chronic myeloid leukemia, and it occurs depending on the lineage of the malignant cell itself. For example, is it chronic neutrophilic leukemia or chronic eosinophilic leukemia? CML is a slowly progressing disorder when there are too many blood cells. So we're not talking about lymphocytes. Too many blood cells made in the bone marrow. And in an adult, the chronic lymphocytic leukemias are the most common here in the Western world. CLL is slow growing, in which too many immature lymphocytes are found in the blood and in the bone marrow. There are, if you think about CML in terms of disease in adults, it is more likely, but it also can occur in children and adolescents. However, the peak incidence is really in the 50s and 60s, and individuals with chronic leukemia have a longer life expectancy, usually extending several years from the time of the diagnosis. So let's first think about CML as being clonal, and it's thought to arise from the hepatopoietic stem cell itself, and this cell is observed in CMLs. They're heterogeneous in differentiation, and it really depends on the stage of the disease. Now, during the chronic phase, the predominant cell is a long-lasting hepatopoietic stem cell. We will see the Philadelphia chromosome in about 95% of patients with CML. And there's also going to be the presence of the BCR-ABL1 protein, which is responsible for the initiation of CML. In contrast, CLL involves malignant transformation and progressive accumulation of B lymphocytes, sometimes T cell origin, but very rarely. The CLL cells will accumulate in the bone marrow, but they do not interfere with the normal blood cell production to the same extent as the more acute leukemias do. This is a significant feature that explains the reduction in the severity in the beginning stages of the CLL disease. The major pathophysiological deficit is that the B cells do not mature into plasma cells that will synthesize immunoglobulins. So this results in a reduction of immunoglobulins in about 60% of individuals. This is called hypogammaglobulinemia. In terms of clinical manifestations, these chronic leukemias advance really slowly and assiduously as well. And about 70% of patients with CLL, they really are asymptomatic when they're diagnosed. And if symptoms do appear, it's really the most common finding is going to be lymphadenopathy. The most significant effect of CLL is that the humoral immunity will be suppressed. Therefore, you have an increased risk of infection with the encapsulated types of bacteria. The level of neutrophils is depressed, which then will add to the risk of infection itself. You might see infiltration, but it doesn't, it's not as invasive as most other organs, but you might see increased infiltration in the lymph nodes, the liver, the spleen, the salivary glands as well. It's very rare that your CNS will be involved. In about 10% of patients, they will actually get a more aggressive malignancy because of the diffuse large B cells, lymphoma, in tandem with the chronic leukemia. And these patients, they're going to complain of extreme fatigue, weight loss, night sweats. They may have a low-grade fever and an elevated level of lactic dehydrogenase, which is an enzyme. They might experience hypercalcemia, anemia, and thrombocytopenia as well. In terms of evaluation and treatment, the diagnosis of the chronic leukemias really depends on your laboratory analysis of your peripheral blood and your bone marrow. And it can be detected based on finding monoclonal B cell lymphocytosis in the blood. The cells are characteristic of being very weak. And there are different immunophenotypes that you don't need to know for our test, but they're CD5, CD19, CD20, and CD23. The treatment of CLL ranges from just observation to actually treating the infections or treating symptoms like hemorrhage and immunologic complications. But because the disease mostly occurs in the elderly, the rate of progression is very slow, and we typically will just observe until the disease progresses. There are current treatment modalities that don't cure the disease, but it will prevent blastic transformation. And the standard treatment consists of combined chemo, biologic response modifiers, and allogenic stem cell transplantation. Lymphadenopathy is an alteration of lymphoid function. It's characterized by enlarged lymph nodes, and this enlargement can occur because, occurs because you see an increase in size, or there's a number of germinal centers caused by the proliferation of increased lymphocytes and monocytes. Remembering these are the immature phagocytes. or there could be an invasion of malignant cells causing lymphadenopathy. But normally your lymph nodes should not be palpable, or they're just barely palpable. When you see enlarged lymph nodes, they're characterized by being palpable, and often they're tender or painful to the touch, but not in every situation. If you have a patient that has localized lymphadenopathy, this really indicates that there's some type of drainage in that area associated with an inflammatory response, or maybe there's infection. So this is called a reactive lymph node. Generally, lymphadenopathy is going to occur less often and is usually seen in the presence of infection, autoimmune disease, or disseminated malignancy. However, if you can palpate a lymph node, it doesn't necessarily mean that there's serious disease. It could mean that there is minor trauma or infection to that area. Depending on the location, the size of the lymph node, this really is going to determine the diagnosis, right? And diagnosing the cause of lymphadenopathy is really important because you're trying to rule out things like lymphomas and leukemias. In general, if you have lymphadenopathy, it can result from 4 types of conditions. Number 1, it could mean that there's a neoplastic disease, or 2, there's an immunologic or inflammatory condition. It could be from an endocrine disorder, that's number 3, and number 4, it could be from a lipid storage disease. And sometimes it's unknown cause, and there could be an autoimmune disease or a reaction to a particular drug, or it could just be generalized lymphadenopathy. Enlarged lymph nodes that become palpable and tender can actually occur due to local or general lymphadenopathy. And when we talk about local lymphadenopathy, we're talking about enlargement of a lymph node to just a specific region, and it's often a response to an inflammatory process of something nearby, and therefore it's draining into that lymph node. It could trigger an immune response, leading to recruitment and proliferation of more immune cells, and then therefore that lymph node increases in size. It becomes palpable. With local lymphadenopathy, it's pretty commonly associated with bacterial viral infections like strep throat, cellulitis, or maybe a skin abscess. However, with general lymphadenopathy, this involves enlargement of multiple lymph nodes at the same time in different regions all over the body. And this occurs in the presence of both malignant and non-malignant disorders. Malignant disease, though, can cause general lymphadenopathy. Think about lymphomas, leukemias, and metastatic cancers. In most cases, these cancer cells can spread to the lymph nodes, leading to lymphadenopathy, and you might even see general lymphadenopathy with HIV or TB or other autoimmune disorders like lupus. The pathophysiology of general lymphadenopathy includes the infiltration of the lymph nodes by abnormal cells, or it could be the activation of the immune system in response to some type of systemic diseases like the ones we've discussed. In malignancies, however, the cancer cell enters the lymphatic system and reaches these lymph nodes, and so they proliferate and cause enlargement throughout. However, in non-malignant diseases, there are various mechanisms that contribute to the general lymphadenopathy, like cytokine release, inflammatory mediators, abnormal immune cell activation or proliferation, or it could be the presence of circulating immune complexes throughout the body. The palpable and tender nature of enlarged lymph nodes or lymphadenopathy is often due to the expansion of the immune cells within the lymph node itself, and this results in increased pressure and sensitivity in that area. To evaluate an enlarged lymph node, you have to think about the total medical history, the physical exam itself, and think about what's happening around that lymphadenopathy. think about the potential additional diagnostic tests that you might need, like imaging, blood tests, or even a lymph node biopsy. And the treatment is going to depend on the underlying cause of lymphadenopathy itself. We're moving on to malignant lymphomas, which are a diverse group of neoplasms that develop from the proliferation of malignant lymphocytes within the lymphoid system. The World Health Organization published the Revised European American Lymphoma Classification, or the REAL classification. And this is based on cell type from which the lymphoma probably originated. So the groups are basically Hodgkin's lymphoma and the non-Hodgkin's lymphomas. 3 major groups of lymphoid malignancies are based on morphology and cell lineage as well. The first one is the B cell neoplasms, then the T cell neoplasms, and natural killer cell neoplasms. Lymphoma is the most common blood cancer in the US, and the incident rates of lymphoma differ in respect to age, sex, geographical location, and socioeconomical class. There is an estimate of about 8,000 and more cases of Hodgkin's lymphoma and 74,000 cases of non-Hodgkin's lymphoma each year. And this is an estimate from 2019, but it said about 20,000 patients would die from non-Hodgkin's lymphoma, but only 1,000 from Hodgkin's lymphoma. So you see there's a higher incidence of non-Hodgkin's. In general, lymphomas are the result of a genetic mutation or viral infection, and globally, the incidence of lymphoma is increased in even more developed countries. Therefore, the investigators or the scientists that are studying the potential risks are looking at diet, obesity, metabolic syndrome, sedentary lifestyle, stress, and even advances in medical care and access. They're also looking at the increase in longevity, exposure to compounds from industrialization as well. The Hodgkin lymphomas are characterized by the presence of Reed-Sternberg cells within the lymph nodes, and these cells are necessary for the diagnosis of Hodgkin's lymphoma. They're not specific to Hodgkin's lymphoma, but in order to diagnose a patient, they need to have the Reed-Sternberg cells. We will see the Reed-Sternberg cells, which is a B cell, in every patient with Hodgkin's lymphoma. It peaks at 2 different ages. First, early in life, and then in the 2nd and 3rd decades. So in your 20s and 30s. And then later in life during the 6th and 7th decades, or in your 60s and 70s. Reed-Sternberg cells are infected with Epstein-Barr virus in about 70% of the cases, and approximately you will see more males than females diagnosed. So thinking about the pathophysiology, this theory is widely accepted that the Reed-Sternberg cells represent the malignant transformation of the lymphocyte. So the RS cell, or the Reed-Sternberg cell, are usually large, binucleated, and will have an occasional mononuclear variant. In rare instances, these cells resembling Reed-Sternberg cells can also be found in benign illnesses and other cancers, including non-Hodgkin lymphomas and solid tissue cancers as well. The triggering mechanism for malignant transformation of these cells is still unknown. However, classic Hodgkin lymphoma appears to be from a B cell in the germinal center that has not undergone successful immunoglobulin gene rearrangement. Therefore, you would see this induced to undergo apoptosis, but it's not working that way. And survival of this type of cell may be linked to infections, again, with Epstein-Barr virus. There are many epidemiological studies that link Hodgkin's lymphoma and Epstein-Barr virus. Now, classic Hodgkin's lymphoma is subclassified into 4 different types. We have the nodular sclerosis Hodgkin's lymphoma, lymphocyte-rich classical Hodgkin's lymphoma, there's the mixed cellularity Hodgkin's lymphoma, and last, there's the lymphocyte depletion Hodgkin lymphoma. And these are all based on the structure of the Reed-Sternberg cell itself and the characteristic of the inflammation cell that infiltrates in the tumor. The manifestations that you might notice in a patient with Hodgkin's lymphoma have to do with the actions of cytokines and the other growth factors secreting and releasing malignant cells. You will see asymptomatic mediastinal masses around a patient's mediastinal area on just a routine chest x-ray. This is not uncommon that it's found that way before seeing the other manifestations. Other than that, you might see cervical, axillary, inguinal, and retroperitoneal lymph nodes. These are commonly affected areas where you'll see lymphadenopathy in a patient with Hodgkin's lymphoma. About a third of individuals will have some systemic symptom like fever, which is typically intermittent. They might have other symptoms of infection like night sweats, itchy skin, fatigue as well. And these constitutional symptoms are usually accompanied by weight loss. And if there is weight loss in your patient with Hodgkin's lymphoma, this is associated with the poor prognosis. We treat Hodgkin's lymphoma typically by first we have to diagnose it with Hodgkin's lymphoma. So we're looking for that Reed-Sternberg cell. Asymptomatic lymphadenopathy can progress undetected for many years, and so therefore getting a good diagnostic history, physical exam, CBC, and other blood studies is important. You're going to include getting a sedimentation rate, lymph node biopsy, again, pathology review for Reed-Sternberg cells, and we're going to immunophenotype for other disease markers. Highly indicative of Hodgkin's lymphoma is looking at the lymph node itself, biopsying it, and finding scattered Reed-Sternberg cells and cellular infiltrate. And that's how they typically will find and diagnose Reed-Sternberg cells. You can also get an abdominal pelvic CT. Bone marrow biopsy isn't recommended in this stage of the disease. However, sometimes your oncologist might ask for one. You can also get PET scans, and these are usually combined with CTs as well. Now, for those patients that have a high risk of relapse, a conventional CT scan for screening are employed just to avoid an increased false positive test, and also increased radiation exposure because of the use of repeated PET scans. The prognostic indicators have to do with the clinical stage of your Hodgkin's lymphoma, the histologic type, the concentration of the tumor cells, the tumor burden, what your constitutional symptoms are. Remember that weight loss is a big one that talks and points to prognosis, and the age of the overall individual. And the effectiveness of treatment is really related to all these symptoms as well. So what are these symptoms? Chemo, radiation, and surgery. For a pregnant woman, really it's going to include just watchful waiting and maybe steroid therapy to suppress until the baby is born. There are some newer treatments including chemos, different types of chemotherapy, radiation therapy, and stem cell transplant, and also monoclonal antibody therapy as well. Now, with the non-Hodgkin's lymphomas, these are a heterogeneous group of lymphoid tissue neoplasms with differing biologic and clinical patterns of activity and different responses to the treatments. It's a generic term for a diverse group of lymphomas. Previously, we used generic classifications of non-Hodgkin's lymphomas, but then they were reclassified once the World Health Organization reclassified them with the real characteristics. So the B-cell neoplasms, which include a variety of lymphomas and myelomas originating from the B cells, different stages of differentiation. And then also the T cell and natural killer cell neoplasms. This includes lymphomas that originate from either the T cells or the natural killer cells. These cancers are differentiated from Hodgkin's because they lack Reed-Zerberg cells and other cellular changes that aren't characteristic of Hodgkin's lymphoma. You are at higher risk for non-Hodgkin's lymphoma if you're an older white male, or if you've had immune disorders or autoimmune disorders, HIV, AIDS, exposure to pesticides, certain cancer-related viruses like Epstein-Barr virus, HIV, hepatitis C, herpes type 8, and immunosuppression that's related to transplantation of organs. Also, if you've been affected with H. pylori, which is a gastric infection, this can also increase your risk for a gastric type of lymphoma. So in general, non-Hodgkin's lymphoma usually attacks patients middle age and over 50 years old. So let's get into a little bit more detail of the overall pathophysiology. Now, with non-Hodgkin's lymphoma, this is a progressive clonal expansion of the B cells, T cells, or the natural killer cells. But typically it's going to be the B cells. It accounts for 85 to 90% of non-Hodgkin's lymphomas. And most of them, the last 15 to 10% have to do with T cells. It's rarely going to be from a natural killer cell. And very small percentages originate from macrophages themselves. These oncogenes are activated by chromosomal translocations, or maybe there's a tumor suppressor loci that's inactivated by deletion of mutation of a particular chromosome. And these subtypes will alter the genomes by oncogenic viruses. There's various subtypes of non-Hodgkin's lymphomas, and these are identified using diagnostic markers. The most common type of chromosomal alteration is translocation, disrupting the genes that encode right at the breakpoint. But unlike Hodgkin's lymphoma, non-Hodgkin's lymphoma will spread in a less predictable way, and it spreads widely and earlier. What you'll see in your patients with non-Hodgkin's lymphoma usually starts as very localized or generalized lymphadenopathy, very similar to Hodgkin's lymphoma. But then you're also going to see cervical, axillary, inguinal, femoral lymph node chains, which are the most common affected sites. The swelling is usually painless, and the nodes have enlarged and transformed over a period of months and years, and then you might see or experience some tenderness. Other areas are the nasopharynx, the GI tract. You might see it in the testes, the thyroid, the bone, and soft tissues. Some patients will even have manifestations, retroperitoneal and abdominal areas, which you'll see masses, symptoms of abdominal bloating or fullness. They might complain of back pain or ascites, which is fluid in the peritoneal cavity. Some patients that have non-Hodgkin's lymphoma will complain of skin rash, itchiness, fatigue, fever, which they don't know where it came from. They might have drenching night sweats and leg swelling as well. Now, there's immediate and high-grade lymphomas that are more aggressive with varied clinical presentations. And then there's also what we call a high-grade lymphoma, and this is a very aggressive type of lymphoma. But lymphomas are generally classified as low, intermediate, or high grade. Okay, so we talked about the intermediate and the high grade. Let's talk about the low grade for a second. This is when the lymphoma itself, it could be termed indolent, meaning slow progression. And usually individuals with low grade lymphomas will have painless peripheral adenopathy. They might have increased spontaneous regression of lymph nodes, which mimic the presence of infection, but no infection is noted. Night sweats with an elevated temperature of 38 degrees Celsius or higher, weight loss, and extranodular involvement are not present in these early stages. And so when you start to see the night sweats and temp and weight loss and enlarged lymph nodes, you can assume that it's a later and more advanced stage of lymphoma. How do we diagnose non-Hodgkin lymphoma? It's by biopsy. And a common finding is you'll see a non-contiguous lymph node, which is not common in Hodgkin's type of lymphoma. So it's one of the differentiating factors besides the absence of the Reed-Sternberg cell. Then they're going to stage it, which is going to determine radiology or chemo type treatments. The staging is going to be based on radiology studies, biopsies, and looking inside and examining the bone marrow through an aspirate. The treatment is going to depend on whether it was a B cell or a T cell, what tumor stage it was, and if it was low, intermediate, or high grade status. Just like Hodgkin's lymphoma, it's going to depend on the symptoms, the age, and the presence of any comorbidities as well. Usually, you'll see treatment with chemotherapy alone, which is adequate for most patients, but sometimes radiation therapy is also included as well. In Burketts lymphoma, this is a B-cell non-Hodgkin's type of lymphoma, and it has a very unique clinical presentation. It's really aggressive, highly aggressive, and it's the fastest growing human type of tumor. There are three main types of Burketts. There's endemic, sporadic, and immunodeficiency related Burkitt lymphoma. The endemic lymphoma or Burkitt's lymphoma, often we see this in Africa and it's linked to the Epstein-Barr virus. The sporadic Burkitt's lymphoma can occur worldwide, and the immunosuppressant or deficiency related Burkitt's lymphoma is most commonly seen in patients with AIDS. Burkitt's occurs most often in children and young adults, and in endemic cases it's usually going to be found in Africa, and it involves a rapidly growing tumor that you're going to see in the jaw, affects the facial bones. In the US, however, Burkitt's is rare and involves the abdomen, which is the characteristic sign. Also, extensive bone marrow invasion and replacement will occur as well. So let's get into a little bit more detail of just the pathophysiology itself. You heard that it's associated with Epstein-Barr virus, and perhaps that suppression of the immune system itself from HIV or malaria, this could increase your susceptibility to being inflicted with the Epstein-Barr virus. Now, B cells are particularly the sensitive cells because of the specific receptors for Epstein-Barr virus. So as a result, the B cells are going to undergo chromosomal translocations that result in this overexpression of the proto-oncogene. Therefore, there's a loss of control over that cell. Typically, it's a translocation of chromosome 8 and 14. There are some other translocations that have been reported between 8 and 2 and also chromosome 22 as well. So in our non-African Burketts lymphoma, the most common presentation is abdominal swelling. Manifestation of these tumors are going to also occur at the extranodal sites. You might see the eye, the ovaries, the kidneys, or glandular tissue like the breast, the thyroid, and the tonsils being involved. And you might see the B-type symptoms. Remember, these are the night sweats, the fever, and the weight loss. Those are called B symptoms. When you have B symptoms, it does typically point to a worsened prognosis. The more common symptoms are going to include nausea, vomiting, loss of appetite. You might have a change in bowel habits, or you might have both. You could also see patients experiencing GI bleeding and symptoms of just acute abdominal pain. In some really bad cases, intestinal perforation and even renal failure can accompany Burketts lymphoma. Usually with Burketts, the presence of the tumor in the jaw and the facial bone, the enlarged lymph nodes, and the bone marrow will contain malignant B cells. Therefore, getting a CBC, checking electrolytes, getting liver and renal function tests are going to be important. You're also going to check for lactate, hepatitis B, HIV, and uric acid as well. And really the treatment is going to be the use of multi-drug regimens. It's pretty aggressive. It's a combination in addition to chemotherapy. And right now, the literature shows that there's no role for radiation in patients with Burketts lymphoma. With lymphoblastic lymphomas, these are relatively rare, and they are also a variant of a non-Hodgkins type of lymphoma. 90% of these happen because of a T cell origin, and the other ones will be from a B cell, but most of them are T cell. It's similar to lymphoblastic leukemia, and some scientists and doctors will say it's a variant of the disease itself. So the pathophysiology of lymphoblastic lymphoma, it arises from a clone of relative immature T cells, and then it becomes malignant in the thymus. So remember, T cells, thymus. As with most lymphoid tumors, the lymphoblastic lymphoma is associated with the translocation. Primarily, it's going to be the chromosome that encodes for the T cell receptor. In this case, it's going to be chromosome 7 and chromosome 14. The manifestations that you're going to see is usually a painless lymphadenopathy around the neck area, and then peripheral lymph nodes in the chest become involved in about 70% of patients. Then you're going to see involved nodes located mostly above the diaphragm. It's a very aggressive tumor presenting as stage 4 in most people. Now, T cell lymphoblastic lymphoma is associated with a unique mediastinal mass, and about 75% of patients will have this mediastinal mass. Because of the apparent origin of the tumor and the location of the thymus itself. Because this mass is pressing on the respiratory system, patients will experience symptoms of dyspnea, chest pain. There is compression of the bronchi and even the superior vena cava as well. That tumor can infiltrate the bone marrow and suppress bone marrow hepatopoiesis. Therefore, you're going to have a susceptibility to infection. Other organs that are associated are the liver, the kidney, the spleen, also the brain. And many individuals will also express the B symptoms, even though this is originating from a T cell. We'll see B cell symptoms like fever, night sweats, and weight loss. The most common therapeutic approach to lymphoblastic lymphoma is combined chemo, very intensive therapy, and in the early stages, you will actually have a very high response rate and an increased survival, about 5 years in children and about 55% in adults. You can get a 5-year survival rate. In children, 80 to 90% survival rate. Now, lymphoblastic lymphoma is easily treated, but there is a high relapse rate, about 40 to 60% relapse in adults. The last of the lymphomas is multiple myeloma, and this is a plasma cell malignancy. It's a clonal plasma cell cancer characterized by slow proliferation of tumor cell masses in the bone marrow, and these masses are associated with lytic bone lesions. So think about the round, the punched out regions of the bone. There are some uncommon variants like solitary myeloma, when there's only a single mass in the bone or soft tissue. This is defined by a lack of symptoms and a high plasma abnormal antibody called the M protein. However, multiple myeloma, you will see the presence of the Bence-Jones protein. And the Bence-Jones protein is indicative of multiple myeloma. In terms of the pathophysiology itself, leading to the clinical manifestations, you're going to see elevations in blood calcium, so hypercalcemia. You might see renal failure, anemia, and in addition to bone lesions. The hypercalcemia and bone lesions result from infiltrations of bone by malignant plasma cells, and then this is going to stimulate osteoclasts to reabsorb the bone. And this process will release calcium, so you'll have too much calcium or hypercalcemia, and then the bone lesion will develop. This destruction of bone tissue is what causes the pain, and this is the most common symptom, or pathological fractures might also be presented. The bones that are most commonly involved in order of frequency are the vertebrae, then the ribs, the skull, the pelvis, the femur, the clavicle, and then the scapula. So think about the vertebrae being the most frequent. So you might have spinal cord compression because of the weakened vertebrae, and this happens in about 10% of patients with multiple myeloma. There's also amyloidosis that can occur, and this is when antibody proteins increase and stick together in your peripheral nerves and organs, your kidneys, and your heart. And so what you'll see is fatigue. You might see purple spots on the skin, enlarged tongue, diarrhea, edema, numbness and tingling in the legs and the feet. You will also see proteinuria in about 90% of individuals because renal failure can affect both acute and chronically, and it's secondary to that hypercalcemia. Going back to that Bence-Jones protein, it leads to the damage of proximal tubules in the kidney. Anemia is usually normocytic and normochromic, and it's going to result from inhibited erythropoiesis that's caused by the tumor cell infiltration within the bone marrow itself. You might even see suppression of the humoral immune response system. You're going to have repeated infections. Primarily, you're going to have experience pneumonias and pyelonephritis, which is a kidney infection. And the most common microorganisms that are involved are those encapsulated bacteria. So think of Streptococcus pneumoniae, Streptococcus aureus, or Klebsiella pneumoniae. Pyelonephritis is going to be most commonly caused by E. coli and other gram-negative organisms. Cell-mediated or T-cell mediated function is relatively normal. It's the humoral or B cell mediated response. What usually leads to the death from multiple myeloma is infection. We diagnose multiple myeloma by checking the symptoms, getting radiologic and laboratory studies, and making a definitive diagnosis is going to require getting a bone marrow biopsy. Bence-Jones proteins can be observed in the urine, and you can also get ELISAs or serum using available enzyme-linked immunosorbent assays. However, the variants of multiple myeloma include individuals in which only free light chain is produced and a rare variant that produces only free heavy chain. And this happens in about 1% of cases. We might look for the M protein or the Bence-Jones protein, but in some cases, neither are produced. In that case, there might be a measurement of another protein called the beta-2 microglobulin, and this can be an indicator or prognosis of the effectiveness or the therapy from multiple myeloma treatment. In terms of alterations of the spleen, we have to understand splenic function, and it's not totally understood, but the normal functions of the spleen helps us to understand the disease. Number 1, phagocytosis of blood cells and particulate matter, like bacteria. Number 2, it's involved in antibody production. Number 3, hepatopoiesis. And lastly, the sequestration of the foreign blood cells. In the past, splenomegaly, or the enlargement of the spleen, has been associated with different disease states, but now it's recognized that splenomegaly isn't necessarily pathologic every time. An enlarged spleen can be present in some individuals without any evidence of disease. However, splenomegaly is one of the first signs of underlying diseases. We already heard of one, mono, but its presence should not be ignored. So even though we know that sometimes it could be nothing, most of the time it is. In conditions in which splenomegaly is present, the normal function of the spleen become overactive. This is going to produce a syndrome that we call hypersplenism. So there are 4 components that indicate the presence of hypersplenism. Cytopenias. Think of anemia, leukopenia, thrombocytopenia, or a combination of these penias. You might have cellular bone marrow, splenomegaly, and improvement after splenectomy. So after you take out the spleen, the patient improves. Therefore, we know that there was hypersplenism. Now, some individuals might seek treatment for problems even though they haven't met all of these clinical criteria, but the relevance and the significance of hypersplenism still is uncertain to most researchers. We call it primary hypersplenism when there's no etiological factor that can be identified, and we call it secondary hypersplenism when there's a presence of another condition that may have triggered hypersplenism. So let's now look more specifically at the pathophysiology of this condition. Acute inflammation or infectious process can cause your spleen to become enlarged. And because of this, there's an increased demand for defensive activities. You think if you have an acutely enlarged spleen, it could be secondary to infection. Maybe your spleen is filled with erythrocytes, and that natural rubbery resilience becomes lost because they are being overfilled with erythrocytes. They can also become fragile and vulnerable to trauma, and this could cause splenic rupture, as we worry about with patients that have infectious mono. Splenic rupture is a complication that's associated with infectious mono. And that's why one of the teachings or the patient education points is not to participate in any physical contact sports. Rupture occurs mostly in males between the 4th and the 21st day of acute illness. There's also something called congestive splenomegaly, and this is accompanied by ascites. Your patient may also have portal hypertension and esophageal varices as well. This is most commonly seen in patients with hepatic cirrhosis. Splenic hyperplasia can develop in disorders that increase that splenic workload and is associated with various types of hemolytic anemias. We also have infiltrative splenomegaly, and this is caused by an engorgement of macrophages with indigestible materials. We call this the storage disease. Tumors and cysts can cause actual growth of the spleen, and metastatic tumors in the spleen are rare, but they can also result from primary tumors of the skin, the lung, the breast, and cervix, all causing splenomegaly. The clinical manifestations overall is going to be a result from the hematologic alterations of the blood components. Sequestering of red blood cells, granulocytes, and platelets are going to result in a reduction of the circulating blood cells in your body. The spleen can sequester up to 50% of red blood cells. Thereby, it can cause an imbalance of normal physiological concentrations of the RBCs within your blood circulation. The rate of splenic pooling is related to your spleen size and the degree of increased blood flow through the spleen. Sequestering exposes the red blood cells to splenic conditions that will accelerate the destruction of the RBCs, and then, of course, you're going to further contribute to the destruction of red blood cells and the decrease in concentration. So anemia is a result of all of those combined activities just talked about. You might also see a dilutional effect as well as the removal and destruction of RBCs. It's going to depend on the degree of splenomegaly itself. We also have to think about white blood cells and platelets. These are affected by sequestering as well. Not nearly to the same degree, though, as RBC sequestering. Again, the size of the spleen is going to determine the number of cells that are being sequestered. The treatment for hypersplenism is a splenectomy, taking the spleen out. However, it's not always indicated. It's necessary to alleviate the destructive effects of the RBCs. The clinical indicators are going to determine the need for a splenectomy, but it's not necessarily a specific condition itself. Splenectomy for splenic rupture isn't considered mandatory now because of possibility of sepsis after removal. Repair and preservation are what we're trying to do. This is considered before the decision to remove the spleen is made. Splenectomy can be performed to treat hairy cell leukemia, Felty syndrome, thalassemia major, hemodialysis, splenomegaly, splenic venous thrombosis, and even thrombotic thrombocytopenia purpura. These would all indicate splenectomy. You can actually live a pretty normal life after your spleen is removed, but your blood cell abnormalities will often still be in existence after we remove the spleen. Your red blood cells become thinner, broader, a little wrinkled. Your WBCs, the count initially will increase and then it's going to plateau. Platelets usually rise after surgery, but then they will also stabilize. Unless you are treating the complications of a splenectomy on time. If you don't, it can progress rapidly to septic shock and also cause disseminated intravascular coagulation, or DIC, which we'll be talking about in upcoming slides. Hemorrhagic disorders can include defects of primary hemostasis, defects of secondary hemostasis, or generalized defects of small vessels. The arrest of bleeding, or what we call hemostasis, depends on having an adequate number of platelets, normal levels of coagulation factors, and also and absence of any defect in a vessel wall. Abnormal bleeding varies widely to massive bleed, such as rupture of a large vessel like the aorta, or maybe it could be a small bleed in the skin, or maybe a small bleed in the mucosal membrane. Diminished or excessive levels of coagulation factors can lead to defective hemostasis or spontaneous and unnecessary clotting. Purpuric disorders, red or purple discolored spots on the skin, this is what we call purpura. This often occurs as a deficiency of normal platelets are necessary to plug damaged vessels or prevent leakage from the tiny tears that occur every day in our capillaries. More serious internal bleeding occurs from events that overwhelm the hemostatic mechanism. Think about rupture of a large blood vessel, again, like the aorta. Maybe there's trauma or a disease associated with massive hemorrhaging. Think about someone that's had an abdominal aneurysm. Between the smaller bleeds and the massive bleeds, there could be deficiencies of coagulation factors that are found with hemophilias. These disorders result in spontaneous clotting and can develop from genetic disorders where your clotting system components do not activate the mechanism of clotting itself. These disorders are known collectively as thromboembolic diseases. Any disorder of the blood that predisposes someone to clotting of blood or thrombus is called hypercoagulability or thrombophilia. You can see in this chart in terms of the defect and the manifestation of that defect. We're going to first talk about the qualitative alterations in platelet function, and this is demonstrated by an increased bleeding time in the presence of a normal platelet count. And what you might see is petechiae, purpura, mucosal bleeding, or bleeding of the gums, gingival bleeding. These disorders can be both congenital or they can be acquired. Congenital alterations in platelet function, or thrombocytopathies, these are quite rare and they're characterized into several different types of disorders, which we'll talk about. Acquired disorders of platelet function, these are more common than the congenital disorders, and they are characterized by three principal causes: either a drug reaction, systemic inflammatory conditions, and hematologic alterations. There are some drugs known to interfere with platelet functions, and they interfere in very different ways. First, the inhibition of platelet membrane receptors, or the inhibition of prostaglandin pathways, or the inhibition of phosphodiesterase activity. Now, aspirin is the most common used drug that affects platelets. It irreversibly inhibits the cyclooxygenase function for several days after administering the aspirin. Non-steroidal anti-inflammatory drugs, or NSAIDs, they can also affect cyclooxygenase, although in a more reversible fashion. So aspirin is a longer lasting. The systemic disorders that affect platelet function are chronic renal diseases, liver diseases, cardiopulmonary bypass surgery, and even deficiencies of iron or folate. Antiplatelet antibodies are also associated with autoimmune disorders as well. First, we're going to talk about thrombocytopenia, and this is defined when there is a platelet count less than 150,000 platelets per microliter of blood. Although most health providers don't consider a decrease significant enough until it falls until about 100,000 platelets, and this is when we start to pay attention. Hemorrhage can be associated with minor trauma, but it doesn't appreciably increase until the count falls into below 50,000 platelets per microliter. This is when hemorrhage from minor trauma can occur. Spontaneous bleeding starts to become an issue when it drops below 15,000, and severe bleeding can occur, and you can be at very high risk at platelet count under 10,000. So what can cause these things to happen? Well, before a diagnosis is actually made of thrombocytopenia, we have to rule out pseudothrombocytopenia. This is a phenomenon that occurs in 1 out of 1,000 to 1 out of 10,000 lab samples, and it is an error in platelet counting when the sample is analyzed by the cell counter. So, pseudothrombocytopenia. Once that's been ruled out, the platelets in the blood cell sample can then, either be retested, or you might wait and get another sample at another time. Thrombocytopenia also may be falsely diagnosed because of dilutional effects observed after someone has had a massive transfusion of platelet poor packed cells to treat hemorrhage. So you're seeing dilutional effects. And this happens when you're giving a patient 10 units of blood or more, transfusing them within a 24-hour period. The pathophysiology of thrombocytopenia results from decreased platelet production or an increased consumption of platelets, or a combination of both. And it can be either congenital or acquired, primary or secondary. Thrombocytopenia secondary to congenital conditions is really what occurs in most different diseases, although each of these conditions are pretty rare in and of itself. Again, going back to the causes: hypersplenism, autoimmune diseases, hypothermia. Viral and bacterial infections can also not only cause thrombocytopenia, but disseminated intravascular coagulation, or DIC, and also heparin-induced thrombocytopenia as well, which we're going to talk about in later slides. When we think about viral or bacterial infections, think about Epstein-Barr virus, rubella, CMV, HIV. The drugs that could cause thrombocytopenia: think of the thiazides, estrogen, chemotherapeutic agents. Nutritional deficiencies like B12 or folic acid can also cause it. Chronic renal failure, bone marrow hypoplasia, radiation therapy, and bone marrow infiltration of cancer can all cause thrombocytopenia. The most common forms, though, of thrombocytopenia result in increased platelet consumption. So think of heparin-induced thrombocytopenia, idiopathic or immune thrombocytopenia, and again, DIC. The clinical manifestations that you might see is a decrease in approximately 50% of the overall platelet count, and this is observed in more than 95% of patients. 30% or more patients with thrombocytopenia are at risk for venous or arterial thrombosis because there is a prothrombotic state in your body caused by antibody binding to platelets, inducing activation, aggregation, and consumption. And so therefore we will see thrombocytopenia in the syndrome name itself. Venous thrombosis is more common, and it results in a deep vein thrombosis, or a DVT, or a PE, which is a pulmonary emboli. You might also see arterial thrombosis that affects your lower extremities, and the manifestation that a patient might complain of is limb ischemia. How do we diagnose? It's really clinical observation, looking to see if the platelet count is dropping. And after 5 days or longer of heparin treatment, you might think it is a heparin-induced thrombocytopenia. On average, platelet counts can fall to about 60,000 per microliter. Treatment is withdrawal of heparin and the use of an alternative anticoagulant if it is heparin-induced thrombocytopenia. Immune or idiopathic thrombocytopenia, we call it ITP. This is a chronic form that has to do with IgG antibody, and it targets the platelet glycoproteins. It is in its acute form. ITP develops after a viral infection, and it's one of the most common childhood bleeding disorders. Many times it is transient, and if we don't have another incidence within 6 months, then we would consider it cured. The basic manifestations that we'll see initially is petechiae and purpura, and this is what most parents will see first. And then if not treated and the platelet count continues to fall, it can progress to major hemorrhaging. Now, ITP in the acute form, this can also occur if there is a drug allergy, if someone has an autoimmune disease like lupus, and what we're looking for is a resolution by resolving the infection or removing the drug that caused the ITP in the first place. With chronic ITP, this is more commonly found in adults and more prevalent in women between 20 and 40 years old, but it can be found in all ages as well. During pregnancy, a woman with ITP may have a newborn that also has thrombocytopenia as well, because the fetal platelets express the same antigen as the mother. So that maternal antibody is going to coat the platelets. Potentially, this is going to result in thrombocytopenia in utero and then again when the baby is born. Overall, how do we diagnose ITP? We're looking for a history of petechiae purpura, history of bleeding, or associated symptoms like weight loss, fever, and headache. On physical examination, you're looking for the location of the bleeding, what type of bleeding, and the severity of bleeding as well. In more minor cases, or in terms of like ITP, you're looking for evidence of infection, like bacterial infection, viral infections, maybe HIV. You're getting a thorough medical history, family history, and you're checking to see if there's evidence of thrombosis in these different areas. You'll get a CBC, a peripheral blood smear, and some forms of thrombocytopenia. You might want to rule out leukemias because they have the initial presentations as well. To treat, first, you would want to see if there is resolution by providing glucocorticoids like prednisone. This can suppress the immune response and prevent further sequestering and destruction of the platelets. You can also try reagents like or treating with IVIG, which is an intravenous immunoglobulin. This is to prevent any major bleeding. The response rate to IVIG is actually pretty good. You might want to use anti-Rho globulin, which is called anti-D. This can be used limited though because the success isn't as high as IVIG, and there's also newer drug therapies now that are available. Now the treatments altogether, they're palliative, they're not curative. We're just focusing on preventing more platelet destruction overall. Now if all of these treatments are not effective, then splenectomy could be in consideration, where we have to remove the spleen altogether because this is the site of platelet destruction. We've already spoke about heparin-induced thrombocytopenias very briefly, but I do want to mention that about 4% of individuals that are treated with unfractionated heparin develop a heparin-induced thrombocytopenia. So it's a very low incidence. It's even lower with the use of low molecular weight heparin, where it's only 0.1%. Heparin-induced thrombocytopenia is an immune-mediated adverse drug reaction caused by an IgG antibody against the heparin platelet factor. The release of additional platelet factors from activated platelets and activation of thrombin can lead to increased platelet consumption and also decrease in platelet count. That begins about 5 to 10 days after administering heparin. And so the hallmark symptoms are going to be thrombocytopenia when you have heparin-induced thrombocytopenia. We're going to see at least a 50% decrease in platelet count in about 95% of our patients. Again, the diagnosis is clinical observation, and we're going to treat by withdrawing heparin or any other use of alternative anticoagulants until your platelet count has been improved. So you have to think then, if a patient needs to have an antiplatelet, what are some other mechanisms or ways that we can keep our patient from being in a hypercoagulable state, but without decreasing their platelets? With patients that have thrombotic thrombocytopenia purpura, they have a type of thrombocytopenia, which is a multisystem disorder characterized by thrombotic microangiopathy, which means it's affecting the small and micro vessels. Your platelets are going to aggregate and include your small vessels like your arterioles or your capillaries within this microcirculation. The incidence is actually increasing, and it's not just because we are improving our ability to recognize TTP, but overall the incidences are actually increasing, and it's suspected that it's because of hemolytic uremic syndrome, which is a drug-induced syndrome that results in thrombocytic cytopenic purpura. There are two types of TTP. There's familial, and then there's acquired idiopathic type of TTP. And the familial type, it's rare, but it is usually chronic and relapsing. We typically will see this type of TTP in children, but if it's recognized and treated early, the child will experience predictable recurring episodes approximately every 3 weeks, and they're going to be responsive to these treatments. When you have acquired TTP, this is more common, but it's also more acute and more severe. And we will see this in patients that are in their 30s, females, and it's rarely observed in infants and older adults. Another disorder of platelets is called thrombocytosis, or essential primary thrombocythemia, and this is characterized when the platelet count is too high. In some labs, it may be a platelet count over 400,000. In other labs, it could be over 450,000. This condition is usually asymptomatic until your count exceeds 1 million per microliter. Then you're at increased risk for an intravascular clot formation or a thrombosis. Hemorrhage and other abnormalities can also occur. Thrombocythemia is chronic. It's a myeloproliferative neoplasm characterized by excessive amounts of platelets being produced. This is going to result in a defect in the bone marrow megakaryocyte progenitor cells. This abnormal blood clotting will commonly occur in individuals with essential thrombocythemia, causing many clinical conditions like leukocytosis, splenomegaly, thrombosis, bleeding, especially in the microcirculatory system. You might have pruritus, and there's also a risk of leukemic or bone marrow fibrotic transformations. The clinical manifestations will vary among your patients. For some, they could be because they're at risk of large vessel, arterial, and venous thrombosis. The most common complication really is the microvascular thrombosis that can lead to ischemia in your fingers, your toes, cerebrovascular regions of your brain. And the primary presenting system of microvascular thrombosis is headache and paresthesia. You might have unilateral or bilateral warm, congested, red hands and feet with a painful burning sensation. This is called erythromalacia. And this is particular in the forefoot or the sole of your toes. It can happen in one or more toes. The lower the extremity affected, this is going to happen more often, and usually it's only one side and not bilateral. The pain can be initiated by either standing, exercise, or elevation. In extreme cases, you might even see acrocyanosis, which is a bluing or purpling color of the hands. And eventually, gangrene can result if not corrected. Arterial thrombosis is more common than venous thrombosis, and it involves the coronary and the renal arteries. Although DVT of the lower extremities and pulmonary embolism are the major sites of venous involvement. People older than 60 with a prior history of thrombotic events have a 25% chance of developing a more severe cerebral or cardiac or peripheral arterial thrombosis. There is a risk for conversion to acute leukemia in about 10% of patients with essential thrombocythemia. You're looking for prior history of thrombotic event, advanced age, duration of thrombocytosis. These are all predictors of future thrombotic complications. So the patients that are over 60 are at greatest risks. And those common symptoms is hemorrhage. Sites of bleeding are commonly the GI tract, the skin, mucous membranes, your urinary tract, your gums, your teeth, especially after extraction, your joints, your eyes, and even your brain. Sometimes your patient may have thrombocythemia, but the GI bleeding that presents can be mistaken for a duodenal ulcer instead. Initial diagnosis isn't very difficult. 2/3 of the patients are diagnosed from just a routine CBC. However, secondary thrombocytosis can occur in a moderate increase in the platelet count that resolves with the treatment or the resolution of the underlying condition. The World Health Organization criteria for the diagnosis of essential thrombocythemia requires that there's 4 criteria being met. The first one is that there's a sustained platelet count of at least 450,000. Your bone marrow biopsy shows a proliferation of enlarged, mature megakaryocytes, and there's no increase in the granulocytes or erythrocytes. Failure to meet the criteria of polycythemia vera, myelofibrosis, CML, or any of the other myelodysplastic syndromes. And then lastly, if there's a presence of the JAK2, specifically the 617F, or another type of clonal marker as evidence of a reactive type of thrombocytosis. Because essential thrombocythemia can be mistaken for CML, there has to be a very careful differentiation because the treatment is going to vary significantly between CML and ET, or essential thrombocythemia. So what is this treatment? It's really directed to preventing thrombosis or hemorrhage. So we need to reduce the platelet count. This is going to be the significant treatment issue. We can provide hydroxyurea, which is a non-alkylating myelosuppressive agent, and it's the drug of choice that suppresses platelet function. However, if you use it long term, it can actually progress into other myelodysplastic disorders like AML or myelofibrosis. We're going to briefly talk about vitamin K deficiency and liver disease as well in terms of disorders of coagulation. And this is usually caused by defects or deficiencies of one or more of the different types of coagulation factors. The first one is vitamin K deficiency, and vitamin K is a fat-soluble vitamin, and we need it for the synthesis and the regulation of prothrombin. This is a procoagulant factor, and the anticoagulant factors within the liver, like protein C and protein S. We don't know the contribution of vitamin K in the overall supply of the intestinal flora, but it is a primary source of vitamin K to our body. Is going to be green leafy vegetables. And the most common cause of deficiency is a parenteral nutrition in combination with certain antibiotics that will destroy your normal gut flora. Now, rarely, though, is your vitamin K deficiency really caused by a lack of dietary intake. However, if you have a patient with bulimia, this can suppress vitamin K dependent activities. If you have vitamin K deficiency, we will try to replace the vitamin K with parenteral administration, like a vitamin K shot. This is a treatment of choice, and it usually is going to result in the correction of the deficiency within 8 to 12 hours. You can also use fresh frozen plasma, but we try to save this for patients that undergo life-threatening hemorrhaging or those that need emergency surgery. In terms of liver disease, vitamin K deficiency or liver surgery, you might have hemostatic derangements with defects in the clotting or the fibrinolytic system and platelet function overall. The hepatic cells, particularly the parenchyma, produces most of the factors that are involved in hemostasis. So if we damage the liver, this is going to result in a diminished production of the clotting factors, like factor 7. This is the first level that's going to decline after liver damage because of its rapid turnover. But also factor 9 levels will decline, but they are less affected and don't decline until the liver destruction is more advanced. With severe liver disease such as cirrhosis, most of the clotting factors are going to be significantly depressed, and the levels of clotting system regulators such as antithrombin, protein C, protein S, and fibrinogen, these will also be lowered as well. The fibrolytic system is commonly active because of plasmin inhibitor and other activators that are unaffected. Thrombocytopenia will occur in affected individuals because there's going to be diminished thrombopoietin as well. Also, there's going to be sequestration or that pooling of platelets within the spleen, which is frequently enlarged in a patient with cirrhosis and associated with portal hypertension as well. When you have these type of patients, you might notice a condition that's similar to DIC. DIC is going to be talked about in the last few slides. Treatment of hemostasis alterations caused by liver disease has to be comprehensive to cover all the aspects of the liver dysfunction itself. Fresh frozen plasma may be necessary. It is the treatment of choice. However, patients tolerate the volume very delicately. So you need to adequately replace all the deficient factors when you are providing fresh frozen plasma. And this is why this modality is the treatment of choice. You can also have alternative modalities such as an exchange transfusion where you're taking off some blood and putting in blood simultaneously, and platelet concentration and plasma administration, thinking in terms of how much platelets are concentrated when giving plasma. Disseminated intravascular coagulation, or DIC, is a complex disorder when you have both clotting and hemorrhaging happening simultaneously. And DIC is the most commonly seen or commonly used terminology that we use for an overall umbrella of consumptive thrombohemorrhagic disorders. It's an acquired clinical syndrome, and what you'll see is first widespread activation of coagulation, but then it's going to result in fibrin clots, median and small vessels, or the microvascular system throughout the body. Well, this clotting is going to lead to blocking the blood flow to organs. When we block blood flow to organs, you're going to have multiple organ failure. The excess clotting results now in the consumption of platelets and other clotting factors, and this is why, in turn, eventually it's going to lead to bleeding tendencies as well, even despite widespread clotting throughout the body. How this is clinically progressing is going to be determined on the intensity of the stimulus, the response of the host, and the comorbidities that also surround the DIC clinical course. And it's going to range from very acute to very severe and life-threatening. It can be characterized by massive hemorrhaging, thrombosis to a very chronic low-grade condition, or chronic conditions that will involve subacute hemorrhage or diffused microcirculatory thrombosis. It can be localized to one specific organ or even more generalized, involving multiple organs, and that's when it becomes a really large issue. The diagnosis of DIC is challenging because there's a complexity and a wide variation of clinical manifestations. The diagnostic criteria has to be established, and this includes systemic thrombohemorrhagic disorders with lab evidence of clotting activation plus fibrinolytic activation and coagulation inhibitor consumption. Lastly, you're going to see also a biochemical evidence of end organ damage or failure. Now, sepsis is the most common condition associated with DIC, and usually it's a gram-negative microorganism. However, there are some gram-positive ones as well. Also fungi, protozoa, and viruses. These are all capable of precipitating DIC by causing damage to the vascular endothelium. But gram-negative endotoxins are the primary cause of this endothelial damage, and it occurs in about 50% of individuals with gram-negative sepsis. Now, DIC occurs approximately in 10 to 20% of patients with metastatic cancers as well as acute leukemias. The adenocarcinomas are the most frequently associated cancers with DIC. Think of lung, pancreas, colon, and stomach cancers. Direct tissue damage like trauma, surgery, burns, this can also result in the release of tissue factor, which initiates DIC by the endothelium. This severe trauma, especially to the brain, can also cause DIC, and it occurs in about 2/3 of patients with systemic inflammatory responses to trauma. Sometimes DIC can be a complication of pregnancy, and about 50% of women with placental abruption, and also 10% with severe preeclampsia or high blood pressure during pregnancy. There are some other causes of DIC that have been identified, but most notably it's due to blood transfusion. The transfused blood dilutes the clotting factors, as well as the circulatory or circulating naturally that occurs with the antithrombins. Therefore, you might have a hemolytic transfusion reaction because the endothelium is damaged by complement-mediated reactions as well. So it could be the dilution of clotting factors, but it also can be endothelial damage by complement-mediated reactions. The clinical manifestations and signs and symptoms are going to vary. There's a wide spectrum of possibilities depending on the underlying disease that initiated the DIC in the first place, and whether the DIC is acute or if it's chronic. Mostly you're going to see symptoms resulting from either bleeding or thrombosis. So it could range from hemorrhaging or oozing out from a venopuncture site or an arterial line, or it can be a surgical wound, or you might see the development of ecchymosis or purpura, petechiae, hematoma. Other sites of bleeding that are common are bleeding in the eyes, like the sclera or the conjunctiva. You might see the nose and the gums as well. But most individuals with DIC are going to demonstrate bleeding at 3 or more unrelated sites at the same time, and any combination can be observed. Shock out of the proportion to the amount of blood loss can also be observed, and hemorrhaging into closed compartments of the body can happen as well, and this could precede the development of shock. There is no single lab test to effectively diagnose DIC. There's not like a DIC diagnostic test. However, you have to look at all the primary and clinical symptoms and a combination of different lab values that have to do with coagulability, but also not having enough platelets to clot. And so you might get platelet counts below 100,000 and then progressively a decrease in the platelet count. This is very sensitive for DIC, although it's not specific, but you're also going to look at prolonged clotting times, the presence of fibrin, decreased levels of coagulation inhibitors as well. The standard coagulation test that you're looking for is prothrombin time. You're also going to get activated partial thromboblastin time. These are tests that have a high degree of sensitivity. Again, not specific for DIC, but sensitive for coagulation. As a result of the consumption of the circulatory clotting factors, these tests are going to look abnormal, ranging from shortened to also prolonged times. Because remember, we're having too much clotting and not enough clotting all at once. We can also detect fibrin split products. These are more specific for DIC. Think about D-dimers. This is widely used for DIC. You're also going to look at the levels of coagulation inhibitors like antithrombin or protein C. This is another way to look for DIC. The treatment is going to be directed at eliminating the underlying pathological condition or what's causing the sepsis. You also have to control the ongoing thrombosis and maintaining the organ function. And you have to eliminate this underlying pathological condition by initiating an intervention in the treatment phase, because you're trying to remove that overall trigger for activation of clotting. Once you can remove that stimulus, the production of coagulation factors in the liver can hopefully be restored to normal plasma levels within about 2 days or so. The control of thrombosis is actually more difficult to obtain, and you can use heparin for this. However, heparin is very controversial for DIC because of its mechanism of action. It binds to and activates antithrombin 3, which is deficient in many types of DIC already. Concurrently, heparin is indicated only in certain types of situations related to DIC, like if you have a DIC because of a promyelolytic leukemia, or if there's retained deceased fetus and you can't expel that tissue after delivery, you might need to use heparin. Organ function is compromised by microthrombi, and therefore there's a risk of losing an extremity because of vascular exclusion. Heparin is also indicated in these type of conditions. They're more acute. It is also useful, But DIC that's precipitated by septic shock, we don't really have enough information yet to see if we can use heparin for those type of instances. So for now, it is contraindicated for septic shock etiologies of DIC. You can also replace deficient coagulation factors like platelets, and when we recognize the treatment modality and see if by giving these coagulation factors, if it's effective, then we can proceed in that route, and the use isn't as controversial as using heparin. We're going to finish our presentation by talking about 3 more topics. The first one is thromboembolic disorders. Think of a thrombus as a clot that is stationary. It just stays against the vessel wall. And we can get thrombi in the arteries and the veins. We want to take note of Virchow's triad, and this is a way to memorize or remember the 3 different components that can cause someone to be more at risk for a thrombus. If there's injury to the vessel, if there is abnormal blood flow, or a hypercoagulability state. We term this clot an embolus once it breaks off from that vessel wall and it's not stationary any longer. This clot starts circulating within the bloodstream. This is called an embolus. We're going to move on to hereditary thrombophilias, which are inherited conditions that increase the risk of developing a thrombosis. And most are inherited conditions. They're commonly acquired, and they are autosomal dominant. You will see mutations that affect platelet count, coagulation proteins, and fibrinolytic proteins as well. This is where mutations are occurring that increase the risk of hereditary thrombophilias. There are tests to diagnose these inherited thrombophilias, like prothrombin time, partial thromboblastin time. You can look at the levels of protein C and protein S. They're more elaborate tests, but these tests are really to detect the precise mutations of factor V prothrombin or the MTHFR, which is also a coag factor. And lastly are the acquired hypercoagulability deficiencies in protein S, C, and AT3, or antithrombin 3. This is acquired. It contributes to a hypercoagulability state. Think of DIC, liver disease, infection, DVT, acute respiratory distress syndrome. These are all associated to acquired hypercoagulability states. This state can include an antiphospholipid syndrome, which is an autoimmune syndrome characterized by autoantibodies against your plasma membrane phospholipids and the phospholipid binding proteins. So as a result, most autoimmune diseases predominantly in females in their reproductive years. This is who is at most risk. The pathophysiology is related to antibodies directly resulting with platelets or endothelial cells, and this can result in damage of the placenta. The predominant diagnostic test used is looking at blood coagulation tests related to antibody inhibitors like lupus anticoagulant. We are also noting that there is a highly effective therapy for this. We can give unfractionated or low molecular weight heparin. with low dose aspirin, and this can help prevent any of the obstructive complications that can happen from deficiencies of protein SC and AT3.